So that was the title. I thought I'd lay out a small agenda for us. So I'll just say a few words about me and my own journey with health informatics. Talk about where my topic fits in with the strategy. Masood was in Liverpool yesterday, so he'll know more about what Simon Stevens had to say about how it fits with the vision for the whole of the NHS. But there were a few very nice sound bites that came out of that speech, I gather. We can talk about the barriers, we can talk about the enablers to this, and we can hopefully have some good discussion. So many of you will know I come from, I work in Sandwell, in the West Midlands on the edges of Birmingham. We serve 500,000 people where I work. We have 30,000 people with diabetes. And that stacks up about 8.5% of people aged over 70. And that's an awful lot of people, an awful lot. High levels of poverty, deprivation, very rich ethnic mix. If you go into Asda, you'll hear lots of different languages being spoken along the way. So my own digital journey, well, my thinking got changed entirely when an opportunity came up a year ago to visit the Veterans Health Administration with a team from NHS England. So that's my declaration of interest, that I had my mind completely blown for what I saw when I visited with the VA. And a lot of what I saw wasn't all that complicated. It just worked. It was simple technology, well applied at scale, that really did work. It was technology that enabled good communication, and it was technology that allowed the clinicians that I met to understand their patients better, and it allowed the patients to understand their clinicians better. Things which we're not talking about tonight, things like secured messaging. So simple, yet so powerful for people to get to know each other. And it was this which meant that when Philip Longman, I don't know whether people know the story, when he wrote this book called Best Care Anywhere, his original task was to destroy the VA. Forbes magazine said, go over there, write a story about the VA, how awful it is, terrible stories we're hearing all the time. And what he saw was completely different. He found an organisation that had some of the best figures for safe healthcare in the USA because of its system. And a lot of that came back to the digital tools and the digital strategy that they had. Well, I got back from my trip last summer and reality bit, because this is what I saw. We are drowning in paper. Masood knows this. It's one of his great challenges working with NHS England. When I talk to junior doctors, it's one of the games I play, because we've got some tools, we all have tools, we all have some electronic tools in specialist care. But I ask them, what percentage of the things that you do can you accomplish digitally? And it's very low. Probably about 75% on average depends on paper. And I find in my organisation, even though we're talking a good talk, we're not walking the walk, are we? That every day new paper-based processes are coming your way. What's that about? However are we going to get to a paper like the NHS if we carry on like that? Yet there was a lot available which we weren't using. So my mission became, could we use those tools? And I actually stopped using my dictaphone last August. And I started using this device I'm presenting on. I started using Siri to dictate my letters in our templates. And I haven't gone back. I haven't used the dictaphone since then. My secretary now works in the clinic with me, and we churn the letters out, paper letter into the hand of the patient, where we can, electronic transmission to our local GPs. Many local GPs haven't allowed us to switch on electronic transmission yet, although we could to all our 111 GPs if they chose to accept it. What's that blue one then? Well, that's what I'm talking about tonight. So this is just part of the strategy. So if we're doing all this, can we use video for virtual consultations with patients? And I began doing that about last October time. And I can't pretend, it's not large what I do, it's marginal to what I do. I probably do something between 0 and 4 of these a week. Depends, it depends on what the patient wants. Depends on lots of things which we'll come back to. So we're using that in the outpatient setting. We used to have a very big home visiting service in my patch. We had 3 specialist nurses appointed to visit people in their homes, the housebound. That got decommissioned. We have a very good setup called iCares in my area, which is about the community matrons, it's about early discharge, it's about preventing readmission, it's about a whole lot more than just people who are housebound. It just connects everything together. It's probably going to be what they mentioned in the Future Hospitals Commission about the hub in every hospital. You've heard them say that? Every hospital will have a hub about early discharge, preventing readmission. It'll probably be that. So what we're imagining is that these iCares people will have a first step with people who might be housebound, and through virtual visiting we can get diabetes specialist knowledge and skills to people who cannot access services otherwise. So we're looking at using video technology for that. Ruth said there was only one model that we were going again with in an iterative way with the VA. Well, that may change, because they have a model you'll be very interested in called Scan Echo. It's a terrible acronym. We must find a better, maybe this group can find a better acronym. Specialist Care Access Network, Extension of Community Health Outcomes. It sounds like it's cardiology, but it's not, doesn't it? Scan Echo. What is it? Well, it's using video teleconferencing with groups of primary care clinicians. It kicked off in, if anybody watches Breaking Bad, Albuquerque, kicked off there, actually. And there the problem was in hepatology. There was a hepatologist, worked in a specialist care centre, and he wanted to try and train regional primary care physicians to be able to manage those very expensive drugs they use in viral hepatitis safely. He published a New England Journal paper showing that when he did this through video teleconferencing, taught and supported primary care clinicians to use these expensive and dangerous drugs, he could get the same outcomes that you could get in a specialist centre. The VA saw this and they've replicated, and they've now got a whole programme for Scan Echo that they run across their country. So you can imagine America's a very big place. They organise themselves in certain ways, and you could be having a session, a Scan Echo session on diabetes, if you were in, let's say, 100 miles from Chicago, and it could be that your nearest diabetes centre that does Scan Echo might be in New York. It could operate like that. And they have several clinicians, and they have a model for that. And their model is about its non-patient identifiable information. So they discuss cases, they have a mini presentation through that, and that works incredibly well for them. And the other part we've mentioned already, the other part of our portfolio of digital healthcare tools is from nothing. We began using Florence in about November, and we've become the biggest user in our health economy very, very fast, because we see its value, and we come to it from the perspective of we're seeing it from the value it gives patients, and from our own values, what we feel about our patients. It adds something to the patient experience. So let's talk about video consultations. That's what we're here to talk about. Of course, it's not just me. You talk to anyone, they all say they're doing it, don't they? Everywhere you go, everyone says they're doing it. That's a headline from EHI from March. It was making headlines in March. Goodness, this has been around ages, but yet it's making headlines everywhere. So a lot of people say they're doing it, but yet it's still making headlines, which is a bit curious. But there's not a lot of evidence out there that there are many people doing it at scale, which is me. I'm not doing it at scale. I can't pretend to I am. There's not a lot of evidence out there that somebody's created a process that you could take from a trust and plug it in at your own trust, which is really important for this. If we're going to scale this up, you've got to have a way of being able to do that very easily. And we all know one of the big challenges about digital healthcare tools is if it doesn't fit with the clinician's workflow, people are not going to use it. So if you don't make this easy to use and fit in with what people do, if it's layered on top of everything else and doesn't change anything else in the organisation, it's probably not going to happen. Now the market leader in this area are Newham, and they also had Health Foundation funding for this project. It's a lot of money, isn't it, Health Foundation funding? So they would have had hundreds of thousands of pounds potentially for this. I believe the size of funding you can get is up to $500,000 for projects like this. I think they had a couple of 100,000 for this. And you can see the technology they're using is very cheap technology. It was plugging £25 webcams, probably even a lot cheaper now, onto desktop PCs to run this. So a few lessons from what they learned in Newham. One of the lessons is, which you can easily grasp, the older you are, the less likely you are to wish to use this. That's the first thing. There's some stats on there about DNA rates as well. They managed to improve their DNA rates through this. You might notice some of the numbers. So this was a project with, a lot of money involved, but we're talking about a couple of hundred consultations involved. So taking it to scale is actually quite challenging, even though you've got specific funding for this. They did some patient questionnaires. They did this over the telephone, they did some in-depth interviews as well, and they got a lot of evaluation data out of that. But again, look at the numbers. They're not very large for an evaluation of this kind. It's quite difficult to get this evaluation information sometimes. But the headline from that were perhaps all the things you would expect. Patients find it convenient. Yeah? It is one of a number of preferences. So if it's your preference, it's great. It's really, really great if it's your preference. A lot of patients said they felt more in control because they had this. And they also said from both sides that they felt they knew each other better as a result of using this technology. DNA rates, is that the DNA rates on there? So DNA rates improved. Have I gone backwards? Benefits realization. I talked about how this could be embedded into workflows and how it might form part of the whole sort of workflow within what we do. And they're now working with the Cerner Millennium product to see if they could embed it into one of many EMRs that we might use. So if people are prepared to try this, they really want to use it again. DNA rates fell by roughly half as a result of using it. They felt it could help build capacity, and that's pretty true. It's one of the reasons why we might all wish to do it. But one of my observations was it's only 2 members of their team that are still doing this after 2 years of trialling it. So clearly they've got some challenges within their own team to truly build capacity within it. On the minus side, there might be groups of patients to whom this is much less applicable. They tried to use Adobe Connect, and their learning was make it simple. Use a tool like Skype. It's much, much simpler. Patients understand Skype. If you say to a patient, would you like to try video teleconferencing to do your consultation, they'll probably say, well, can you say that slowly? If you say to them, would you like to try Skype for us to talk? They'll know exactly what you mean. They'll get it first time. Skype has some extra enhancements just recently you can link multiple people through Skype. And I found out just a few weeks ago that you can share your screen through Skype as well. So it's becoming much more valuable than it was. I believe it's now one of the Microsoft products. So if anyone uses Microsoft Link, this is what you're using when you use Microsoft Link these days. So avoid complex software. They had a lot of money. They had a lot of investment. They had an external evaluation team doing the evaluation, but yet they still found this really hard. So it shows just how challenging these adaptive change problems are. And Christian's question about what can the network do? If we start to find ways of overcoming barriers, I think that's going to be one of the key things you can get from networks, but how you have the resilience to get past barriers. And one of my reflections is, having heard them present, I think they won a Quality in Care Award for diabetes for this work as well. When I heard them present, that was very clear that it's still being driven by professionals. I would have liked to have heard a bit more of the patient perspective and seen it was being driven by patients now as well. So on to some practicalities and barriers and enablers within it. But clearly, because we're talking about voice over the internet protocol, you've got to have internet. It's not going to work otherwise. Krish and I tried to do a Skype a couple of weeks back. What happened, Krish?
We picked the phone and
we ended up having a telephone conversation, didn't we? Because there was a problem with Wi-Fi my end. So you're always going to have problems with quality. You'll have a lot of concerns. You'll have colleagues, you'll have other people saying, but what will the commissioners think? What will they say? Will we get paid for this? If we don't have somebody sitting in front of me, the commissioners won't give us the money. Well, in Newham, they overcame this. They had some very sensible grown-up commissioners who said, it's obvious, it benefits patients, it benefits everyone. Of course we'll support you to do this. It's about being grown up. Is it secure? We'll come back to that in just a second. My chief executive officer used to work down that way. So when he arrived in our organisation a year ago, he said, why aren't you using Skype? So it was very easy for me to do this. It just overcame all the IG issues that people get bogged down with. He wanted us to do it. And I know many people do get stuck in the cul-de-sac, cul-de-sac, I suppose you could say, to coin a phrase, the cul-de-sac. So it was very interesting to find this document, which is on this slide. If you Google Skype consultation, NHS, you'll get this document, freely available. From the QUIP work stream, QUIP Digital Technology, a brief guide to Skype remote consultations. I'll probably have to stand over here to read it. So it's got things like service quality, everything you need to know about service quality. Information governance, is Skype secure? So I suspect you should just download that, you give that to your IG people. And that'll probably be just what you need to do. And you will overcome, I think, pretty much every IG issue they can give you.